Female reproductive pathology, a good topic, not too hard, not too easy, but some of the things could be a bit confusing. This I made mostly from the book. What is not from the book has its resource linked below. I think it's very important for you to use official resources, namely your professors and teachers. Please do not disregard the lectures. They are very, very useful. First question of the female reproductive tract pathology is about the nonneoplastic diseases of vulva and vagina. We will touch upon the basics and then we'll dive into the pathology. UTIs and STIs are closely related because of the closely related anatomy. A person having unprotected sex with somebody who has chlamydia, for example, can get a UTI from it or can get an STI from it. They can come together, they could be a complication of the other. Just keep that in mind. They're not the same, but they are related. Infections of the lower female genital tract. Let's brisk through the more important agents. HSV1 and 2. They can cause herpes labialis, they can cause herpes genitalis. Second one is more oftenly causing the herpes genitalis. First one causes herpes labialis more oftenly. Keep in mind there are primary infections first, so there is initially some infection with it with more general symptoms like a headache, fever, etc. And then the virus lays dormant in the nerves, and when you have some stress, immunodeficiency, antibiotic usage, you're sick with something, it can re-emerge. Next, we can talk about chlamydia, which we are mostly interested in when we discuss the upper genital tract because it spreads upwards and it can cause pelvic inflammatory disease, which we fear. Vaginal candidiasis, also called yeast infection colloquially, are fungal infections of the vulva and vagina. Also very stereotypical infections. They can happen to anybody, but they are mostly seen in people with diabetes, pregnancy, antibiotic usage, immunodeficiency, etc. Why pregnancy? Why some of the other things? So much of it is depending on the lactobacillus activity. So lactobacillus is a part of the normal microbiome of the vaginal canal, and if it is inhibited, there is a lessened effect of its acid producing capabilities, and pH increases, and this inhibitory effect against many foreign hostile microbes is lost, and then we can get a yeast infection more easily. For example, human papilloma virus, specifically the low risk 6 and 11 and some other less common ones, they cause condyloma acuminatum in the area, which are warts. They are benign exophytic lesions, right? And if we look at their histology or microscopy, we see choliocytosis. Very important to mention. We'll discuss it later on. Next, we can discuss the syphilis, the secondary syphilis condyloma latum, which is a wart-like lesion. Verrucae, warts, are benign squamous proliferative lesions caused by HPV. There are over 130 types of HPV. Most of them, of course, we don't need to know. But what is important here is how the virus works. We will discuss it later when we discuss choliocytosis, but when the virus infects cells, it produces some proteins by hijacking the cellular mechanisms, which affects the cells themselves, and these produce certain characteristics in cells, and therefore many HPV subtypes cause some proliferation of the squamous tissue they infect, causing a wart. Of course, different serovirus or servovars of HPV cause different types of warts based on which area they infect. So Verruca vulgaris, the common wart, or anogenital warts, which is the one relevant to our discussion here, and the condyloma acuminatum or venereal warts, are in the anogenital area caused by HPV 6 and 11. And for example, with syphilis, it's a wart-like condition because it looks like a wart, but it's not HPV. Choliocytosis is what happens when a cell of the HPV family infects basal epithelial cell. So We call them coliocytes when we look at them in the microscope. You can take a look at the picture. The cells on the left are normal cervical cells. The cells on the right have some enlarged nucleus, enlarged cell, maybe a perinuclear halo or cavitation, which you can see the cytoplasm is much brighter in the right side cells than in the left side cells. So what exactly happens? You have the immature basal cells at the bottom of the squamous epithelium. They are infected by an HPV virus. The HPV virus utilizes the cellular mechanisms to produce certain proteins. The certain proteins affect the way the cell is growing, and therefore it ends up this way. Very important to remember that other proteins are seen with some other servovars of HPV, like the high-risk HPV, that produce the E6 and E7 proteins, which are the oncogenic ones. And those are the ones that push for dysregulation, leading to mutations and therefore cancer. Other noteworthy infections of the lower genital tract, less important, but try remembering some of them. So we can talk about the non-infectious pathologies of the vulva and vagina. Bartholin cyst is a simple one. You have glands on both sides of the orifice of the vagina that secrete some lubrication. What happens when there is obstruction of the duct? For example, you have some other etiology causing an inflammation in the area, closing the duct. Well, these secretions, they accumulate, causing a retention cyst. It's painful. It's a painful swelling. When discussing the epithelial disorders, leukoplakia is a super important term to remember, but it's just a descriptive term. It's not a pathology on its own. Leuko means white and plakia means plaque. So everything that looks like a white plaque, you could refer to as leukoplakia. But which pathologies look like a white plaque? Well, it could be some inflammatory dermatosis, psoriasis and chronic dermatitis. When you learn about skin pathology, you will come across them. They are very important. But for the female genitalia itself, lichen sclerosus and lichen simplex chronicus and neoplasia are the most important ones. Lichen sclerosus heterotrophicus, nowadays called lichen sclerosus, believed to be an AI-mediated mechanism causing epidermal thinning, hyperkeratosis, and sclerosis of superficial dermis. Macroscopically, the skin looks smooth and like porcelain or parchment paper. If it gets so severe, this can cause the vaginal orifice to be constricted. When a thing like this occurs on the penis, we call it xerotica ballantois. If it occurs extragenitally, we'll call it extragenital lichen sclerosus, but it's not so important. It is not pre-malignant, but the same patients who have this are also at higher risk of vulvar SCC. Lichen simplex chronicus, aka squamous cell hyperplasia by the book. Chronic rubbing or scratching to relieve itchiness causes the skin to turn thick and leathery. But this is a reactive process, so this is just the skin's reaction to your injury of it. It is not malignant or pre-malignant. Lichenification is the process that our department used to describe what happens, which is acanthosis and hyperkeratosis, which are very important when you look at the microscopy and you see the thickened epidermis, the acanthosis, and the hyperkeratosis. Again, no cellular atypia because it's not malignant, it's just reactive. Benign exophytic lesions of the vulva, condyloma acuminata, the wart caused by low-risk HPV, condyloma latum, the wart-like lesions caused by secondary syphilis, Fibroepithelial polyps and squamous papillomas are both benign exophytic proliferations, both with not so much known etiology. So we finished with the vulva, and now we can discuss the vagina. Developmental abnormalities of the vagina. I would like to give special attention to the ethylstilbestrol, DES, a synthetic estrogen, an estrogen receptor agonist. It was used between the 40s and 60s to try and lower risk of miscarriage in high-risk pregnancies. What happens to the daughters of mothers who used it during their pregnancy, among many other influences around the body? Most importantly, it increased the likelihood of having vaginal adenosis many times over. What is vaginal adenosis? It's the persistence of columnar epithelium, so endocervical epithelium in the upper vagina. Now the upper vagina arises from the Mullerian duct along with the cervix and other areas of the female reproductive tract. Therefore, it is covered by columnar epithelium. The lower two-thirds arise from the urogenital sinus and therefore is covered by stratified squamous epithelium. During embryogenesis, there is replacement of the upper one-third by stratified squamous epithelium. What happens if there is persistence of aisles of columnar epithelium there? Vaginal adenosis. Why do we care about it? Because this related vaginal adenosis has a higher risk, much higher risk of clear cell carcinoma, which is an adenocarcinoma, a very rare one, that already appears in young age. We really don't want it. It led to the discontinuation of using this. Now keep in mind that estrogen receptor agonists are still used today for many other reasons, but we will not use this and we will not use them to prevent miscarriage because we don't want to precipitate this. Keep in mind that you can see it. When you look, for example, on colposcopy, you will see redder areas than the normal pink vaginal mucosa. Vaginal cysts, congenital cysts. The first thing to mention is the Wolffian and Mullerian ducts give rise to our reproductive tract. They exist in all of us initially in start of embryology, and then one of them regresses while the other ones give rise to the reproductive tract. In women, it is the Mullerian duct which give rise to the reproductive tract, while the Wolffian duct, also called the mesonephrid duct, regresses. If it persists, now we call it Gardner duct. But this Gardner duct can also be cystic, could be fluid filled, for example, and therefore we will call that a Gardner duct cyst. Mullerian duct cysts are the same idea in women or in men, but let's say in women there is persistence of some area of this Mullerian duct which became cystic, and now it's a Mullerian duct cyst. Okay, vaginal cyst, acquired one. Keep in mind, Bartholin cysts and sebaceous cysts are more vulval cysts than vaginal cysts, but I thought about including them here as well. Bartholin cysts you should already remember. Sebaceous cysts are those cysts that can occur anywhere on the body where there are sebaceous glands. Again, it is a retention cyst. There is some obstruction and then some cyst with the fluids of the gland. Epidermal inclusion cyst, also called epidermoid cyst or inclusion cyst or keratin cyst, is the same idea, but what happens is the hair follicle is obstructed and this inclusion cyst has some different fluid in it. Endometriosis. Endometriosis, simply put, is the presence of endometrial tissue outside the endometrium. But it's more complicated than just that. It's the presence of endometrial glands and stroma outside the uterine cavity. It is a chronic condition that usually presents with chronic pelvic pain and impaired infertility, though technically it can be asymptomatic. Only 2% of it are vaginal cases. The rest, far more commonly, for example, are in the ovaries, posterior broad ligament, anterior and posterior cul-de-sac, uterosacral ligament, and also other areas like GIT, urinary system, and even extra pelvic structures. It is debatable whether it is hormonally active or not, meaning some of our professors look at it like it is hormonally active and some are not so sure. Online trusted resources like publications often suggest it is estrogen dependent, meaning that with the ovarian cycles, the hormonal cycles, estrogen peak cause it also to proliferate, for example, and that could trigger the pain. Etiopathogenesis theories. The only one really important to remember is the first one. Retrograde menstruation is when you have the blood flowing backwards through fallopian tubes to the peritoneum. And that the theory is that this somehow can implant the cells somewhere. But for example, it won't explain how it reaches the pleura or something like that. So none of the theories are exactly a perfect fit for all cases of endometriosis, and therefore none of them have really been chosen. But Samson theory is the most important one to remember.